It is a great honor to introduce Dr. David Bakhos from France. He is a MD, PhD, and completed his medical school and training and tours in France, and then was actually at House Institute between 2012 and 2013, working with some of the researchers here. And he's going to give us a talk today. We welcome him. So thank you very much for joining us.
Thank you for the introductions and thank you for your invitations. So I'm going to talk about the metabolic profile of perilymph cochlear implant patients. So I have a full positions in Tours as a professor. Tours is a small but nice city located in the center of France. And we have the chance this year, just before the French containment, that Dr. Pang, Dr. Wilkinson, and John Galvin visited us. And Tours is a part of the Loire Valley with a lot of castles. So it's a nice city. If you want to come and visit us, it will be with pleasure. So I am a professor at the two university hospital. I am an ENT surgeon, but also a CI surgeon. I work also at the Faculty of Medicine to teach to medical students. And I work at two different research units. The first one is imaging and brain in a team called Biomarker, Imagery, and Therapeutic. It's a French research team. And another team, this team, it's called INRA. It's an animal platform to study the animal models. And we can perform surgery, but also some imagery as CT scan and MRI. And here you can see a tiger inside the CT scan. So I'm going to talk about vestibular and hearing disorders. And as you know, many patients complain about vestibular and hearing disorders. But how we make currently the diagnosis? We use physical examinations, tonal and vocal audiometry, some objective measures as ABR, and imagery as CT scan and MRI. It's the same for dizziness, and we can add video nystagmography and vestibular evoked potentials. But even with all this examination, with all the objective measure, and with all the imagery, we don't know where is exactly the damage inside the inner ear. It's often the case that there is no clear pathophysiology or causes. It's a case, for example, for Meniere disease. There is a lot of hypotheses, but we don't know really where is the damage. It's the same for vestibular neuritis or labyrinthitis. For autoimmune disease, there is sometimes some hearing loss, but we don't know why. And the same for sudden hearing loss. And even with sensorineural hearing loss, we don't know the etiology for between 10 and 40% of the patients. So we are now going to focus more about sensorineural hearing loss because the pathophysiology is unclear. The treatment is validated using hearing aids or cochlear implants, and the prognostic factors in auditive performances has been identified as the etiology and duration of deafness. But for example, for etiologies with multiple causes and damaged sites, and we don't know exactly where is the locations of severe damage inside the inner ear, just using imagery or objective measures. For deafness durations, it's also difficult to quantify by the patients or the ENT, even using self-report. During an abatement, patients, when you ask him, since how long you have your deafness, he say, oh, many years, but many years mean nothing. And even when we try, he say, oh, maybe 5, maybe 10 years. So it's difficult to quantify. And there's so multiple causes. It could be genetic, environmental, as noise or age. And usually there is irreversible structural damage to auditory hair cells and associated neurons. And the etiology could be intricated. There is a multiple sites of damage. It could be the cerebral vascularis due to aging, vascular ototoxicity. It could be also the hair cells, inner or outer hair cells, due to noise, ototoxic bugs, aging, genetic malformations. Could be also the synapse due to noise, loss due to hair cell death, and could be also the spiral ganglion neurons. So there is a lot of damage inside the inner ear. And currently, we have no specific biomarker linked to sensorineural hearing loss, I mean, linked with etiology or duration of deafness, but also linked with mechanisms and disease evolutions, disease severity. So considering this, if we want to improve the management of sensorineural hearing loss patients, we need to find some biomarkers linked to etiology and duration of deafness is necessary. But also we need to improve our knowledge about metabolic pathways is necessary to propose a personal treatment. The objectives of our project are in front of a patient with hearing loss. We want to find some biomarkers linked to the etiology or duration of deafness, but also to improve our knowledge about metabolic pathways. As it, we can find some therapeutic target and then develop new medications in order to restore auditory function. But what is a biomarker? What is a perfect biomarker? A perfect biomarker, you need accessible fluid, a reliable technique. You need to be able to quantify something in the fluid. It needs to be sensitive and specific. The rates need to be correlated with medical condition, and it need also to allow a personal treatment. So for hearing loss patients, what is the best accessible fluid and which analysis will permit to have different profiles linked to the etiology? The accessible fluid for hearing loss patients, it could be Perilymph during a CI surgery. We can have a sample of Perilymph because we have access to the round window membrane. It could be also maybe blood, and we will see later why blood could be important. And which analysis could permit to have different profiles. So I will tell you that we use omic techniques called Metabolomic. So the accessible fluid for hearing loss patients could be the Perilymph during a CI surgery, or maybe the blood. The technique could be Metabolomic. And what is a Metabolomic? Metabolomic is a part of the omic study. It permits to investigate metabolomic pathways, and it's a systemic study of the unique chemical fingerprints that specific cellular processes leave behind. It permits to identify some metabolomics, and metabolomics are end products of cellular processes. So there is several omic techniques. There is a genomic, it will study the genome, the transcriptomic will study the RNA, proteomic will study the protein, and metabolomic will study the metabolomics. So it permits to have some profile link with phenotype. Metabolomic now is developed in several neurological disease, for example. So you need a sample, it could be urine, blood, feces, so, and maybe Perilymph. Then you have to do the metabolic determinations using leaking chromatographs with high resolution mass spectrometry. It will allow you to identify the small molecules called metabolomics, and then to do some analysis and interpretations. For example, you can have two different populations. Here, for example, the normal hearing subjects and here hearing loss patients. And there is a difference of metabolomics between the two groups. So then you have to do some more analysis to investigate the metabolomic pathways. So the accessible fluid is Perilymph from blood. The technique that we use is metabolomic with a high resolution mass spectrometry. And we did first an analytic study. It was a proof of concept in order to validate the Perilymph metabolomic analysis, because the major technical challenge was due to the low perilymphatic volume available, and we published this study in 2018. The Perilymph that we sample was around 0.8 microliter, but even with this low volume, we were able to identify 147 metabolomics. And here you can see the most important metabolites that we found inside the perilymph. Then we did a clinical study with 19 CI patients, and the patients we included have different etiologies. So it was quite difficult to study the etiology because 5 were due to age-related hearing loss, and 2 noise, and 1 was due to meningitis. So it was difficult to correlate metabolomics with etiology. So we decided to correlate it with the duration of deafness, and we find a correlation between duration of hearing loss and N-acetylneuraminate. N-acetylneuraminate is a metabolomate. It's sialic acid in cell membranes, and we published it in 2019. As a result, we did a statistical analysis to compare the metabolome profile from perilymph fluid of cochlear. And in green, it's the subjects, the patients with more than 12 years of hearing loss. And in red, the subjects with less than 12 years of hearing loss. We divided the group using the median of hearing loss, and we included only the patients with a precise durations of deafness. And then we were able to identify the metabolomics who permit to differentiate these two groups. And the most important was N-acetylneuraminate. N-acetylneuraminate is acid sialic, and it's a part of the membrane cells. So maybe it's due to apoptosis. It's more important when you have more deafness. Then we did also some other analysis to study the pathways, but as we have just few patients, it was not really significant. So accessible fluid could be perilymph during CI surgery, the technique metabolomic, and we can quantify the metabolomics inside the perilymph fluid. As the feasibility of metabolomics is demonstrated, new opportunities will arise to improve diagnosis, but also to improve knowledge of pathogenesis. Our project is to develop metabolomic biomarker to establish links to damaged sites and or duration of deafness, but also to find rates correlated with medical conditions with different etiologies of hearing loss. To investigate medical pathways using a metabolomic analysis, we need to correlate pathways with the etiology of hearing loss to find therapeutic target, and then to develop new medications. So the next step is to study the normal perilymph and compare with pathologic conditions in animals. So we did it last year. It's necessary to use large animal models to compare human CI patients. So with sheep, because sheep, when you drill the temporal bone, you have to open the hippotympanum, and then you find easily the malleus and the cochlea, and here the round window membrane. And here you can see the facial nerve. And then when you open the round window membrane, there's a lot of perilymph fluid, more than in humans. So it's quite easy then to investigate the fluid with a metabolomic. And the anatomy of the cochlea is quite the same as human, it's 2 tons and a half, but also the hearing physiology is quite the same, I mean, in terms of range of frequency. We can also put a CI implant. I mean, it's here you can see a human CI implant inside the cochlea in a sheep. So last year we investigate normal perilymph in 6 sheep, and it's the red. You can see the normal perilymph. And in green, it's a controls from cerebrospinal fluid. And as you can see, cerebrospinal fluid, the the results are quite homogeneous compared to normal hearing perilymph. Normal hearing perilymph in sheep, there is a lot of variability intra-group between the metabolomic profile. So it means that we need to match the normal hearing with the induced hearing loss here. So now our project is with sheep. We are going to do some CT scan, then ABR, and we will sample collection of normal hearing perilymph under general anesthesia. Then we will induce hearing loss with noise on the other ear. We will perform again the ABR, and then we sample the noise-induced hearing loss here. We sample the perilymph. After, we want to do some metabolomic analysis to see the different profile between the normal ear and the ear with the noise-induced hearing loss in order to see to investigate the metabolic pathways. So, I mean, we did the first surgery last Monday, and we sample also the blood before and after we induce the hearing loss. So we expect that with this project, with a perilymph and blood study, with metabolomic analysis, we can have different profiles. For example, if we have some metabolomics links with interleukin-6, JAK, or TGF, it means it's more the inflammation pathway. If we have glutamate, caspase, it means it's more apoptosis and cell loss, and it's due to age-related sensorineural hearing loss. If we find metabolomics related to oxidative stress, it's more due to noise-induced sensorineural hearing loss. And maybe the pathways will be also integrated in a patient. Then we can use some medications, for example, for noise-induced sensorineural hearing loss, we can use hydrogen gas to prevent the hearing loss. In case of age-related sensorineural hearing loss, we can use a neurotrophic factor as a DFNB. And in case of inflammations, we can use corticosteroid. As you know, I mean, a lot of CI surgeons use corticosteroid in order to decrease the inflammations when they perform a CI surgery. But there are still some challenges because how to determine the metabolic profile without risks for inner ear disease, how to do the perilymph sample in a patient with hearing loss without risk. We need to improve the technique, and a team from Hanover, Schmidt and Hall, in 2017, they developed a new technique to sample the perilymph with a microglass capillaries. So it's promising, and they did some proteomic studies. Blood could be also interesting if the results are promising, or other samples as feces seem promising for a lot of disease, and actually a lot of teams using metabolomic are going to use feces when there is unknown etiology. So blood is interesting because this year there is a team from Toronto. They published a nice study and they find correlations between protein in blood and hearing loss and balance disorders. In case of hearing disorder, they find in blood some protein called prestin, as you know, and for balance that find autoferlin. So it means maybe with blood we can find some nice profile. A link with hearing loss etiology and maybe balance. But in our team, we are more focused on hearing loss. And to do these studies, I use a platform, use DNA-based immunoassays. There is still some challenge because how to deliver the drugs inside the inner ear, even if we can determine the metabolic profile linked with the etiology, how to deliver the drugs. Should we use the drugs with or without CI? And maybe some operations with microbubbles could be interesting. some operations is you inject some gel inside the middle ear, and then you use ultrasound, and the microbubbles will go from the middle ear to the inner ear, and then the drugs will be delivered inside the inner ear. And inside the bubbles, you can put some neurotrophic factors, some medications, corticosteroid. So there is 2 studies with some operations using microbubbles to use it in inner ear. This is one from China, published in 2019. So you can see the controls with the epithelial surface of the round window membrane. They did it with a guinea pig. And when they use 3 courses of ultrasounds, it permits to have some pore-like opening. And when they use 5 courses, it permits more pore-like opening. And they did ABR in order to be sure there is no deteriorations of hearing thresholds at 2 months. So the results seems promising, and we are going to develop it in our team, because there are some researchers that are specialized in some operations. They did it with some dermatology practitioners. So in the future, when a patient complains of hearing loss, maybe with blood and metabolomic analysis, we can have his metabolic profile. And then, if, for example, it's due to age-related hearing loss, we can use some operations with microbubbles, and inside the microbubbles, maybe neurotrophic factor, maybe stem cells, and then restore the auditory function. So maybe in the future, maybe the patients in the future don't need the CI surgeons. We will see. I want to thank all the members of our team. The INSERM team for the sound operation project is Professor Boakaz and Dr. Escroff. For metabolomic project is Professor Blasco and Professor Aymon. They are from the biochemistry departments. At the INRA members, they help us a lot to develop animal models, and they permit us to do the imagery, the surgery, and housing of the sheep. The hospital, because there is another CI surgeons called Professor Lescan. So we are 2 CI surgeons. The students, Dr. Trin and Dr. Bolo, they did a nice job, and they permit to develop the model, the animal models, and of course the patients. And I want also to thank John Galvin, because he helped us a lot. I mean, in order to review our paper, but also for the design of the study. It's always interesting to speak with him, because he has always new ideas. So thank you a lot, John. And I want to say you Merry Christmas, and thank you for your attention. I hope soon you can visit us, and I can go back to US to see you when COVID will be finished. Thanks.